This is a qualitative study on decision-making by prostate cancer physicians during active surveillance. Active surveillance is increasingly being used worldwide, but there's no consensus on patient selection and follow-up protocols. There are many different published protocols and significant heterogeneity in clinical practice. Our objective was to explore and identify factors that influence physicians' decisions while monitoring patients with prostate cancer on active surveillance. We performed 24 in-depth interviews with U.S. prostate cancer providers in 2015. Interview transcripts were coded independently by 2 researchers. Matrix analysis and in vivo were used for organization and further analysis. We identified 8 key themes that explain the heterogeneity in active surveillance practices: physician comfort with surveillance, protocol selection, beliefs about the utility and quality of testing, years of experience and active surveillance exposure in training, concerns about inflicting harm, patient characteristics, patient preferences, and financial incentives. Physicians agree that active surveillance is now a standard management option and that the publication of long-term data showing a low risk of mortality has made them comfortable with active surveillance. An example quote, "I think there's this general acceptance as we see more literature coming out from different groups showing that it's safe." In terms of protocol selection, despite awareness of published surveillance guidelines and prospective protocols, many physicians design their own protocol. Here is a representative quote, "If you look at the major series that have been published, there are variable approaches to active surveillance. I don't think that any are validated, and so I feel my assessment is just as good as any other expert in the field." Physicians had very different beliefs about the quality and utility of tests, ranging from PSA, markers, MRI, and biopsy for monitoring during active surveillance. For example, one physician said, "Most of the studies show that PSA is not a reliable trigger for intervention, and so we get it, but then we don't know what to do with it, and it just ends up scaring patients." Physicians reported variable exposure to active surveillance during training due to a greater emphasis on procedural skills. A representative quote is, "We train people to do something. We are by nature doers, and active surveillance is not really a part of what a surgeon is wired to do." Providers also had concerns about inflicting harm, either by performing too many invasive tests with repeat biopsies versus the risk of missing disease progression, as well as concern about medico-legal risk. Here are some representative quotes. "It's possible that you missed the window of curability on your watch. They could be hurt by that choice. That's a lot of responsibility. There's obviously some degree of liability." Patient characteristics were another major factor that went into decision-making. Many providers mentioned age, comorbidities, and a history of compliance were considered in their management decisions. Physicians also reported considering patients' financial and insurance status before recommending certain tests that may or may not be covered. Patient preferences were also a factor that were considered when deciding on the type and frequency of follow-up tests during active surveillance. One physician said, "The ones that choose active surveillance, it's a little bit self-selective. The super nervous types don't tend to choose it." Finally, financial incentives were a theme that was mentioned. The providers felt that they do not affect monitoring practices, but do affect initial uptake of active surveillance. A quote was that in Europe, where there is no fee-for-service system, the uptake of AS is exponentially higher than in the U.S. "I believe in surveillance. You watch the tumor all the way to the time you wheel the patient in the operating room." In summary, there was general agreement on the importance of active surveillance, but we identified multiple barriers to the uptake of active surveillance in the U.S., and found a tension between providing standardized care versus personalized medicine. We had several actionable recommendations based on our findings. More research is needed actually comparing different active surveillance protocols to help determine what is the optimal patient selection, type, and frequency of follow-up tests. There's also a need for more training on active surveillance during residency, including how to select and manage patients during active surveillance, and a need for continuing medical education, including shared decision-making and more data on testing options.